All right, let's talk more about ischemic stroke. The initial goal is to establish eligibility for TNK, TPA, which is indicated within 3 hours of onset in patients when they have the measurable defect. So if a patient falls asleep at 2200 and they wake up at 0600, and they wake up with the defect at 0600, we go back to 2200 because that's the last time normal. We have to assume they had a stroke sometime during the evening that they were sleeping. Basic things we want to get is a CBC, BMP, glucose check, make sure there's no blood on the CT head, there's no bleeding, signs of bleeding. The optimal time is we can get this as soon as possible, because we lose 1.9 million neurons per minute. Now, select patients, we can extend it out from 3 hours to 4.5 hours. Now, doing a thrombectomy, we have up to 24 hours, but here again, we want to go as soon as possible. 1 to 2% of the patients with TNK, TPA will convert to hemorrhagic stroke. That has a high mortality, about 50%, with these risks mostly being from protocol violations outside the time window or blood pressure greater than goal. We want to admit these patients to receive TPA or TNK for ICU monitoring. This is part of the protocol. We're looking for risk of bleed, and we're trying to mitigate any problems they have, making sure their blood pressure is controlled. Ischemic stroke management requires frequent neurological assessments. Initially check Q 15 minutes for 2 hours, then Q 30 minutes for 6 hours, then Q 1 hour for 16 hours. So these have to be done in the medical ICU, and they have to be done by trained nursing professionals that have certification for checking these patients. We want to check the head CT for neurological changes at 24 hours prior to starting platelet medications. Once patients receive the TPA or TNK, the BP goal is less than 180 or 105, and you can use labetalol and nicardipine. Those would be your first lines. IV TPA TNK reduces debility from stroke by about 30%. It receives, remember, it does early reperfusion in roughly just 15 to 30% of the large vessels. And then aspirin is only given after dysphagia evaluation and after 24 hours after TPA or TNK is given. If given within 40 hours, reduce the risk of recurrent strokes at 2 weeks. Now, there is a question of using, and we'll talk about this just so you have this knowledge. Those with an ABCD2 score greater than 4, it's possible, and you may see this, is I don't think it's going to be tested much on boards. This is just giving you information because there is some controversy with this, is a 21-day treatment of aspirin and Plavix for 90 days alone shows a reduced risk of strokes. This is only in the acute setting. Chronic setting of dual aspirin and Plavix has no benefit in the long-term treatment. It just increased risk of bleeding is noted. Remember, heparin, besides the sub-Q heparin that's used for basic prophylaxis, heparin drips have shown no benefit, and it can show harm because you have increased risk of bleeding. Treatment of ischemic stroke. Treat if the blood pressure, if only greater, now this is for the patients did not receive TPA or TNK. We're going to treat high blood pressure only if greater than 220 over 120. Only if greater than 220 over 120. This is the patients that have not received TPA or TNK. For patients eligible for thrombolysis, BP must be lowered to stabilize below 185 to 110 before thrombolytic procedure is started. We want to maintain a BP of 180 or 105 for 24 hours after thrombolysis treatment. Now, there's been discussion in the past about lowering the blood pressures for certain goals or reperfusion goals. This is kind of up in here because there's studies going back and forth on there, so we won't really even discuss that too much. Antiplatelet therapy, which could be aspirin. It's going to be mainly aspirin. Sub-Q heparin, 500 units TID, or Lovenox sub-Q, appropriate DVT prophylaxis dose for prophylaxis in mobile patients. All right, we have to get some laughs. Your mother used to work this corner. We have to laugh during or else we'll cry, okay? These subjects, it's not the most exciting thing. I know the neurologists just cried when they heard me say that it's not the most exciting thing in the world. And some of this is just straight information that we have to get in our brains. So we're trying to make this as painless as possible. All right, thrombolytic therapy in a CVA. Indications for patients are greater than 18 years old while presenting within 3 hours of acute onset for ischemic stroke is measured by a neurological deficit, or in select cases, if it's less than 4.5 hours. The CT scan shows no bleed and no evidence of multilobar infarction or with hypodensity greater than 33% of the cerebral hemisphere. Meaning if you have these huge, large strokes, it's probably, first of all, this is greater than the 3 hours, but also as you give this medication, you're gonna have a high risk for bleeding. Contraindications to getting thrombolytic therapy, previous stroke or serious head trauma within 3 months, BP greater than 185 over 110 despite treatment. So there's lots of treatments that can be given so that the patient can effectively get these medications. Recent invasive surgery procedure with the prior 2 weeks. So worried about bleeding. INR greater than 1.7 on warfarin. And can you try to lower this to get it within the 3 hours? Yes, you can try if you wanted to try PCC. Increase PTT if heparin was given in the preceding 48 hours. You can try using protamine sulfate. Evidence of active bleeding, GI or GU bleeding in the prior 21 days. And platelet count less than 100,000 or hematocrit less than 25 or the glucose less than 50. Here again, you can give dextrose to get the glucose up. You can transfuse platelets. You can transfuse blood. But you have to think about why is the blood low and what is this going to be a benefit to this patient. Recent MI in the previous 3 months or history of intracranial hemorrhage. Don't want to give this if there's any history of intracranial hemorrhage. Symptoms suggest a subarachnoid hemorrhage. Remember, the imaging isn't perfect. Remember, you want to begin antiplatelet therapy with aspirin or clopidogrel for after 24 hours. All right, here's another little thing that kind of wake us up. Woke up after Narcan. After arriving, he was initially drowsy, but then woke up and became aggressive, both verbally and physically. He was attempting to throw his own feces at staff. He required Haldol and Versed. He's continued to be agitated and was ultimately intubated. This is the story of our lives, okay? This propensity towards violence and harm towards providers. We'll talk more about this in our lectures. I just want you to think about if an incident like this occurs, you need to report it, you look for your personal safety and look for the safety of you and your staff. And yes, you are not alone. These incidents happen everywhere in all hospitals, all types of facilities, and everything from urgent cares all the way up to tertiary hospitals and quaternary hospitals too. When to start anticoagulation after ischemic stroke with atrial fibrillation? This can be a tough question. When do we start this? Starting a DOACs at 3.5 days versus 8.3 days. Before starting a DOAC, 22% had IV thrombolysis and 7% had thrombectomy. Primary outcome, recurrent ischemic stroke, symptomatic brain hemorrhage, and unclassified stroke and systemic embolism within 90 days. So guess what? The outcomes did not differ. The outcomes did not differ. So DOAC treatment within 4 days appears safe. The timing decision for each patient, it still needs to be an individualized decision. Remember, robots and AI have not taken over because we still need to have individual decisions. And the outcomes of this were about the same. So we can consider starting DOAC sooner. All right, transient ischemic tach. Transient ischemic focal neurological symptoms occur originally defined as lasting less than 24 hours, but this definition has changed. You still may see it in your textbooks, but it's incorrect. The new definition is absent of infarction on neuroimaging regardless of symptom duration. That's a TIA. Let's go back to that. A TIA is absence of infarction on neuroimaging regardless of symptom duration. Before it was less than 24 hours. Now it is, we'll say it again, absence of infarction on neuroimaging regardless of symptom duration. Usually short, less than 5 minutes. They can be 1 hour duration, can have a sudden onset of hemiparesis, hemisensory loss, vision changes, or changes in speech. You would get a head CT, you have a cardiovascular evaluation, cerebral vascular imaging is required due to the high risk for a full stroke. from going from TIA to an ischemic stroke. Secondary prevention of strokes, treatment of hypertension, very important, tobacco and cessation. If you ever get a question and it kind of lists things, always go with tobacco cessation. It's going to be your first choice. Improvement of physical activity and diet high in fruit, fiber, and vegetables, and low saturated fat. If you ever get a question choice of what's the best diet, and Mediterranean diet is present, that is always the best answer that has the best evidence. No matter what is going on, what fad, the Mediterranean diet has the best evidence. Anticoagulation for atrial fibrillation based off the CHADS-VASc 2 score. Secondary prevention of stroke, carotid endarterectomy for symptomatic intracranial artery stenosis of 70 to 99%. We already discussed if greater than 99%, if it's fully blocked, medical therapy is just as good or better. And less than 70%, we can cause harm by doing a surgery. The surgery is not benign. Statins for those with an LDH greater than 100, and new research saying less than 70, unless it's a lobar intracranial hemorrhage due to amyloid angiopathy. Antiplatelet therapy for secondary prevention. Aspirin would be low-dose aspirin, plus dipyridamole is superior to aspirin alone. Clopidogrel can be used. Do not use aspirin and clopidogrel greater from 90 days. Remember we talked about using these two for 90 days can be controversial, but there is some data that shows that may help. In some cases, using dual therapy for 90 days. We want to make sure we have glucose control. Risk of developing seizures following acute stroke can be 5 to 10%. Remember, anytime the brain gets remodeled, everything from a stroke, from hemorrhagic to ischemic to traumatic brain injury, we have a risk of seizure. I want you to think of seizures being a storm inside the brain, and this storm can fire up after the real estate has been remodeled. Think of it as a tornado in the brain, and the tornado occurs after the real estate has been modified. Aphasia is a disturbance in comprehension, sensory production of spoken or written language. You can have global both sensory and motor. It's a branch of the middle cerebral artery or internal carotid artery. Broca's is motor or non-fluent. Broken speech involving the dominant frontal lobe MCA branch. Broca, broken speech. Wernicke's is sensory or fluent. Word salad, when you have the Wernicke's lesion, remember the word salad, Broca's spoken speech. Wernicke's word salad. Speech is fluent, but does not make sense. This is like one of your administrators talking to you about why your pay is being lowered. You hear words, the words kind of are there, but it doesn't make sense. You can have parietal lobe involvement, MCA branch involvement. You can have pure word blindness, can't read. This would be in the posterior cerebral artery. Conductive aphasia, can't read, can comprehend and read. This is the branch of the middle cerebral artery. Cerebellar stroke, we need to rule out BPPV, which is benign paroxysmal positional vertigo, needs to be ruled out. This is done by doing the Dix-Hallpike maneuver, lasting this can be for seconds and minutes. This is triggered by movement. So BPPV is triggered by movement. We do the Dix-Hallpike maneuver to rule this out. Vertigo is in 25% of those over 50 who come for emergency room for acute onset vertigo. Signs and symptoms, limbs ataxia. So for cerebral stroke, limb ataxia, patient falls on the side of the lesion. Inability to ambulate, persistent hiccups. Dysmetria is going to be loss of balance and poor coordination of walking, speech, and eye movements. Dyskinesia, inability to form rapid. This is why we do this test right here and repeat it on both sides. Dyskinesia, rapid inability to form rapid alternating muscle movements, and then nausea and vomiting. The HINTS exam. Now the HINTS exam, this is where we're doing is this. The purpose of this HINTS exam is to determine should we get this patient in a stat MRI. We're worried that they may have an area of lesion in the posterior portion of the brain that the CT imaging does not get well. The MRI will get it. Now the HINTS exam, I do want you to know is the scoring for this when you're doing the testing for this to show that this is very useful in determining if we should get an MRI or not. This was performed by neural fellows. It wasn't performed by people who are not neurological fellows. So this may skew some of the test results. And there's basically 3 parts to this. The head impulse test, this is basically, and I don't know how you could say that you can do this test effectively on an 85-year-old woman where you're taking their head and you're shaking it violently back and forth, and then you look at their eyes and see if their eyes have a deviation. That's the head impulse test. Now, nystagmus, you're going back and forth, you're keeping their head straight, and you're having them follow your finger, and you're looking for a nystagmus of the eyes. The test of skew is that you're covering one of their eyes, you have them follow your finger, and then you take the covering off, and you see if the eye deviates up like this. So I have my eye covered, they're going like this, have me follow the eyes, and then I take that off, and if I see that eye deviating upwards, that's a positive test of skew. Any positives, you would get an MRI. One positive will require further testing. That further testing is going to be an MRI. CT scan is less sensitive, as we discussed, in detecting posterior fossa abnormalities. MRI will be needed. All right, we're going to have a continued discussion on a HINTS exam. We're going to go over it again because, yes, it's important. HINTS exam done on patients within hours or days of continuous ongoing vertigo and spontaneous nystagmus. Series of tests evaluate patients with vestibular syndrome to see if the cause is a possible posterior stroke. One positive finding will require further workup, that is an MRI. Head nystagmus, that's where you rapidly shake the head and you look at their eyes to see if they deviate after you shake them rapidly. I don't know how this can be performed properly in an older person. And you're looking for lag with the corrective saccades. So you're looking for, see if the eyes kind of deviate over. Nystagmus is that you observe the patient's eyes and rest for nystagmus and in the direction, so you have them flick left and right. You're looking for a bidirectional nystagmus, that's a positive. Skew is then the examiner covers and uncovers the eye, the time observes any vertical eye movement, and upward or downward movement of the uncovered eye suggests a central cause. Deviation of one eye that is being covered, followed by correcting after uncovering it. You also want to do is talk about doing the Dix-Hallpike maneuver as a test for benign positional vertigo, in which is short episodes of vertigo initiated. Remember, benign positional is initiated by movement, and there's no spontaneous nystagmus. Basilar artery occlusion is vertigo, nausea, ataxia, headaches, diplopia, dysphagia, dysarthria, hemiplegia, hemisensory loss, pseudobulbar signs such as, what is a pseudobulbar? Is facial palsy, dysphonia, dysarthria, dysphagia. You have rapid onset of altered levels of consciousness with brainstem dysfunction. You can have pupil response, facial palsy, and impaired cough or gag. Abnormal seizure-like activity. This can be mistaken for posturing. Can quickly decline to locked-in syndrome. This has to be the worst disease of all time, where the patient is there but cannot really correspond just for limited eye movements. Decreased consciousness, somnolence, amnesia, and hallucinations. Can a temporal and occipital infarctions from embolus or distal clots, embolization can also occur, can result in hemiplegia, which is visual loss on the left or right side of the vertical midline, can affect one or both eyes. Treatment can be warfarin, say Doax, or aspirin. This too is a beta artery occlusion. You really want to get them in and see if they can be a thrombectomy.